Ryley.
Ryley.
Need my baby Ryley.
It's the first baby in 18 years. You can't call it Froley.
Says who?
Okay, I found your boat.
Great.
How?
We get ourselves arrested.
Oh, Jesus.
No, Sid, this border guard I sold pot to, has agreed to get us into Bexhill. Nicely ironic, eh? We break into prison.
Please join me in welcoming Dr. Ryley.
Thank you, Mark. I'm now extremely nervous, wondering why I'm here. This is a great venue. I've never been here before, and I am a resident of Brookline, so I know, but I am now convinced this is the place to be. So again, my name's David Ryley, and I am flattered that the Coolidge Corner Film Foundation has invited me to introduce this first film in their series of Science on Screen. So Children of Men, it's a film from 2006, science fiction, directed and co-written by Alfonso Cuarón with a great cast, among others Clive Owen, Julianne Moore, and Michael Caine, all spectacular actors and actresses. The year is 2027, and it follows 2 decades of human infertility. Society is on the brink of collapse. Humanity is facing the grim reality of extinction. It's based in the UK, which apparently is the only remaining functioning government. And illegal immigrants from around the world who are escaping the chaos and war that has become pervasive are immigrating to the UK, and they're applying some oppressive laws to try to control these people as they flee. Our protagonist is Theo Ferrone, who is played by Clive Owen. And his job is to assist a refugee known as Key. And what you need to know about Key is she is the representation of hope in this dying world. She's the only known pregnant woman on the planet. So the themes of Children of Men are hope and faith in the face of overwhelming futility and despair. And these themes are abstracted from the book upon which it is based, written by P.D. James, as you see here. And just to quote from the book, "It was reasonable to struggle, to suffer, perhaps even to die for a more just, a more compassionate society, but not in a world with no future where all too soon the very words justice, society, struggle, evil would be unheard echoes on an empty air." He's using infertility as this desperation that man has nothing to live for, and it's an excellent analogy, but I'm pleased to tell all of you that all is not lost, and infertility is something that we have become so successful at treating. Now, there's this perception that infertility is increasing. It is not. Access to treatment is increasing. 10% of reproductive age women, and that's typically defined as age 18 to 44, are infertile, and about 15% of couples. About 21% will seek our services to help them overcome their subfertility. And this represents about 6.1 million women and couples in the United States. When do we evaluate these couples? Well, typically after 12 months if they've been unable to achieve a successful conception, if the female partner is under 35, 6 months if the female partner is over 35. 85% of couples attempting conception will achieve a successful pregnancy in that 12-month time period. When they do not, they are deemed infertile, and therefore they seek our services so as to overcome their subfertility. So as I had mentioned, infertility is not increasing, but we're trying to get pregnant when we are older due to the socio-demographic shifts that have occurred in our society. Greater numbers of women are attempting pregnancy at older ages. They are less biologically fertile, but our treatments have allowed them to overcome this subfertility. So let's look at some of the factors that impact a couple's fertility, the most important being the age of the female partner. So when you look at assessing fertility and age, you have to look at the classic studies that assess fertility in populations attempting conception. And the best study was published in 1957 on a group of men and women known as the Hutterites. And this is a religious order that emigrated from Switzerland to the Midwest in the 16th century. And basically, these couples are under a religious and paternalistic dictate to practice attempted conception from the time of sexual maturity up until the menopause. And they shunned any of the environmental influences such as those listed here, promiscuity, drugs, and alcohol, known to impact one's natural conception rate. I would never have been accepted into the Hutterites. And that would be the least of the reasons I wouldn't be accepted. So when you look at this data, and it was a classic study, anywhere from a third to a half of the women were infertile by the age of 40. Think about that. Think of the ages that many of us are trying to get pregnant now. We're waiting off until we're 40, but up to 50% of couples are known to be infertile in this age group, 87% by the female age of 45, and the average age that a couple who's having regular monogamous intercourse will achieve their last live birth, not the last pregnancy, but the last live birth, is at the female age of 40.9 years. And these trends showing decline in fertility, so fertility rates on the y-axis versus age on the x-axis, have been shown to be very similar in many population-based studies over time with consistent data throughout. And why is that? Well, it's not about just getting pregnant, it's carrying that pregnancy to term. And as women get older, more of the eggs that are involved in reproduction are genetically abnormal, so that as that female partner gets older, her miscarriage rates get higher. And if you include both clinically recognized and unrecognized pregnancies, so pregnancies that occur without the partner knowing it, she has never missed a period, miscarriage rates for women over 40 are as high as 75%. So it's not just getting pregnant, it's trying to achieve a live birth that we can attempt to overcome. So what's the impact of the male? Well, it's really hard to figure out what role the male plays in declining fertility as couples get older. We can really only assess the one biologic parameter that allows us to figure out that male's inherent fertility, and that's his semen analysis. So we know as men get older, there's a decline in their semen volume. There's less normal sperm. The sperm doesn't move as well. There doesn't seem to be any real impact on the male age on the concentration of the sperm. And unfortunately, when you look at studies and try to assess male fertility and his contribution to the infertile couple, they don't really control for the impact of the female age. We do know in couples who are undergoing treatment, for instance, for IVF to help them overcome their fertility, and couples in which the male partner is over 50, they definitely have lower successful pregnancy rates, higher pregnancy loss rates. So we do take that into account, but it certainly doesn't have the same contribution to the decreased success that the advanced female age does. Of concern is the fact is that when men get older, there's increasing data to suggest that the offspring of these couples are impacted by rare genetic disorders, and particularly the autism spectrum. And this applies to men typically over the age of 50. So that's something that we have to keep in mind as we're helping these couples achieve a successful conception. Well, let's look at lifestyle. What do we do that either harms or helps our ability to conceive? As we all know, smoking is bad. You don't need a reproductive endocrinologist to tell you that you shouldn't smoke. But it's amazing when our internists tell us it might cause lung cancer, it might cause heart disease, we still smoke. But when you tell a couple that they're trying to get pregnant that this smoking is bad, suddenly there's a reason to stop. In the male, it's known to impact their semen parameters. It might cause erectile dysfunction and therefore create another cause of infertility. In the female, it will lower her estrogen levels. It will have toxic impacts on her ovaries. The pregnancies that result in these smokers are more complicated. It will reduce their fertility. And increasing data shows that the offspring of couples, be it the male or the female who smoke, have higher rates of childhood cancers. Certainly, when we look at couples who are undergoing IVF therapy for the treatment of infertility, these patients do not do as well as patients who don't smoke. They have significantly higher miscarriage rates. And basically, their response to our treatment is like adding 10 years to their reproductive lifespan. So a 20-year-old will respond like a 30-year-old if she's a heavy smoker, a 30-year-old like a 40-year-old, and a patient coming in at age 40 who smokes often responds like someone who's menopausal and basically is not successful. smoking is clearly a significant reproductive toxin. Here we see data from a study that was done in basically Great Britain, late 1990s, published in the New England Journal of Medicine. And they interviewed women who were pregnant. They were already pregnant, and the UK has great data because they have a socialized healthcare system that allows them to keep track much better than we can do so in the States. And they were asking, they asked these, the patients, their lifestyle factors and tried to correlate it with how long it took them to get pregnant. And the factors that impacted a prolonged time to conception are listed here. So if the male smoked more than 15 cigarettes per day, it increased their time to conception. Alcohol, more than 20 beers per week, and age over 45. In the female, smoking, excess caffeine use, not moderate caffeine use, being overweight, a body mass index over 25 kilograms per meter squared, and an age over 35. So if you look at no negative variables, if you look at the time to conception for the couples, if they had none of these parameters, 83% of those couples will conceive a successful pregnancy in 12 months. With one negative variable, it was 71%. I need a different set of glasses here. I do surgery. If you had two negative variables, it was 61%, 51%, and essentially, if you had 4 of those variables, your chance of having a successful conception over 12 months was significantly lower than the patients who did not, so that it took you 7 times longer to conceive, and you had a decreased conception rate of 60%. So these are parameters that we can affect when we're trying to get pregnant to improve our chances. And certainly obesity is a problem, and one that is increasing. Women who have a BMI over 25 kilograms per meter squared, which translates into a 5'5" woman being over 150 pounds, it takes them 2 times longer to conceive than women of normal weight. And in the male, it impairs spermatogenesis, lowers sex hormone levels, and might cause other problems associated with subfertility. And this is really important. Take a look at these maps. When you look at these color-coded maps provided by the CDC, and the state-by-state analysis that's showing us the increased rate of obesity in the United States. If you're looking in 1990, most of the people diagnosed with obesity, the percent of the population being so diagnosed was less than 20%. And look at the percent now in 2010 that have obesity. This is impacting fertility significantly. This is our data that we published at Boston IVF, looking at the response of infertile couples to our treatments and what impact weight may have. And for women who were defined as being obese, which is a BMI over 30 kilograms per meter squared, they had a significantly decreased odds of success from IVF. When they were defined as being severely obese, they had a 68% lower live birth rate than women of normal weight. That is significant when you think of these trends of obesity not only causing infertility, but impacting the success of our treatments. It is a significant problem. And so, how do we focus on timing? How can we tell a couple to improve their chances? Well, it's not very scientific. The best time to have sex is when you want to have sex, but for the purpose of getting pregnant, it's at the time of ovulation. It doesn't take much of a reproductive endocrinologist to tell you that. And if you look at day -5, which is defined as 5 days prior to ovulation, which is day 0, if you had intercourse once on day -5, your chance of achieving a pregnancy in that cycle is 10%. It's up to 33% when you have it at the time of ovulation. So there's a lot of urban legends out there that you have to have sex in the middle of the menstrual cycle every other day to preserve the sperm and all these different ideas. It's not the case. If a woman's doing an ovulation predictor kit and she's trying to time the best time, it's the day of the surge and the next day, and that couple, independent of how many times they had sex before then, will have maximized their chances. So finally, when a couple comes to me and we're trying to assess the cause of their subfertility, this is the distribution of their diagnoses. 20% of these couples, the female partner is not ovulating regularly, and we can often give them medication to get them to ovulate and to time it with intercourse. The most common single diagnosis is the male. That's the most common cause for infertility, is impaired spermatogenesis. 20% of the women may have pelvic inflammatory changes, often due to STDs that cause blockages in her tubes. That couple will require IVF. A small percentage will have surgical requirements to fix problems in their uterus or cervix that's impacting conception. In 25% of the couples, it will be unexplained, which basically means all the testing is normal, but often because they're getting older, it's harder to conceive a successful pregnancy. And that's what I'm going to briefly focus on, and then we can get on to the movie. The best way for couples to overcome their unexplained infertility is in vitro fertilization. In vitro fertilization, in vitro is Latin for outside the body, fertilization is fertilization. And basically what you're doing, every month of a woman's reproductive life, she has a group of eggs that have the capacity to ovulate. And so she produces her own natural hormones, and out of that group that's ready, one is released and all the others die off. With IVF, we supplement her hormones and we rescue those others from dying off. We're not stealing future eggs. We're not depleting her egg supply. We're not causing future infertility. We're rescuing eggs that her body was about to depart with. So she takes those medications. Sorry, it must have been on a timer. She takes those medications, and in a simple outpatient procedure that takes about 10 to 15 minutes, the eggs are retrieved. They're mixed in a petri dish with her partner's sperm. Embryos are created, and those embryos are transferred into her uterus in a procedure that is similar to a pap smear. Boston IVF published this data in the New England Journal of Medicine because we had the largest database that answered the question, if a couple with unexplained infertility comes into our office, what are the chances that that couple will leave with a baby? Now understand that when patients have this diagnosis, their chances of achieving a pregnancy on their own per month is less than 5%. So we need to have treatments, and that's what IVF is, to markedly improve that if these treatments are going to be worth it. So we looked at a series of patients from 2001 to 2005. It was over 6,000 patients. And basically, we were able to tell these couples what their chances were of leaving with a baby. Now recognize this isn't per IVF cycle. It takes a certain number of cycles to achieve this success. But if you're under the age of 35, your chance of leaving with a baby, would be between 65 and 80%. Don't leave the baby with me. 65 to 80%. In the group from 35 to 38 years, it was 57 to 78%. And you can see those numbers, far higher than their projected chances on their own. This shows us the increase in IVF success rates, and this stops at 2004, and I couldn't find a slide real quickly to take us up to the present day, but it's been increasing since its inception in the 1970s and 1980s. When you look at the national database, they're just going to tell you per cycle success rates. That doesn't define what the chances of a couple are coming into my institution of leaving with a pregnancy that will give them a baby. But per cycle in the young group, you have a 40.7% chance of taking home a baby, much lower in the older group, but again, with multiple attempts at treatment, a very high chance of achieving success. So there are three basic success stories from IVF I want to end with that really makes me proud to be part of this process. One is the fact that because of our improvements in the way we develop embryos and the way we culture them, all those stories you hear about multiple pregnancies are markedly decreasing. We've increased the success of IVF, and we're transferring less embryos to do so into the uterus. In 2002, 65% of pregnancies resulting from IVF were singletons, and now it's up to 72%. With a twin rate that's gone from 32% down to 27%. But the most important piece of data is that triplets, very high-risk pregnancies, are now less than 1% of successful IVF pregnancies. And we're increasing the per-cycle success rate with much less high-order multiples. And that's what I'm most proud of when we consider how we're trending our success over time. And IVF is not just for infertility. It's for patients who carry significant diseases and are at risk for conceiving children impacted by what are often life-threatening diseases. There's not a month that goes by in my office that I don't have a couple present who are known to have genetic mutations that give them a very high risk of having a child with a significant disease, or unfortunately, patients who gave birth to children who have since deceased because of significant life-threatening diseases. Common examples include cystic fibrosis and Tay-Sachs disease. These couples are not infertile, but I can think of no better reason to do IVF to eliminate the risk of these couples having these children. So we do what's called pre-implantation genetic diagnosis, where you remove a cell from the embryo before that cell has grown into a differentiated structure, and you identify which embryos are affected, which are not, and you allow this couple to have a healthy conception. One of the most common forms of infertility is recurrent miscarriage. And particularly as we get older, many couples present where they keep getting pregnant, but they are miscarrying. We can prevent that. We can assess embryos that are genetically normal and those that aren't normal, discarding the abnormal and lowering this couple's miscarriage rate below 10%, affording them the opportunity to overcome what is an incredibly emotionally impactful event in their lives that happens over and over again. We can eliminate that for them. And one particular topic that's near and dear to my heart is that we can preserve fertility for both men and women who are facing therapies that are what we call gonatotoxic. Patients who are undergoing cancer treatments are surviving today. In the 1970s, when men and women were facing treatments for cancers known to affect couples of reproductive age, such as breast cancer, cervical cancer, lymphoma, non-Hodgkin's lymphoma, leukemia, those couples had a survival rate, typically those men and women had a survival rate of less than 50%. It's now above 80% because of our aggressive use of chemotherapy agents. That's a success story. But it has allowed these couples to focus on the quality of life, and the most important parameter that couples cite as being important in the quality of life is their ability to have children. By preserving embryos or eggs prior to these treatments, we suspend their fertility in time. So a woman who comes in with breast cancer, who is going to face likely ovarian failure from her chemotherapy, not to mention the fact that it could be another 10 years before she's cleared to get pregnant, her fertility will be preserved, and it's a spectacular process. And because of our improvements in egg freezing, which prior to 2012 was considered experimental, we are allowing many women who've had to defer their childbearing because of the demographic shifts that are occurring in this country, particularly with our professional needs and our need to defer our childbearing. It allows them to wait until they're both economically stable and they don't have to look for Mr. Right, they don't have to compromise. This might sound like a small thing, it's a huge thing. And freezing eggs is now a very successful process. And to quote from this article in Bloomberg Business Week, imagine a world in which life is not dictated by a biological clock. Egg freezing allows us to do that. So this is why we do what we do, and unlike the movie you're going to see tonight, there's not futility, there's not despair. The treatments for infertility are spectacular. I'm honored to be part of it, and I hope you enjoyed tonight's movie. Thank you.